of the upper extremity, muscles that move the upper extremity, and muscles that are in the upper extremity. So we finished up with muscles on Friday that stabilize the scapula, that inserted onto the scapula. And we're going to start out today with muscles that have their origin from the scapula and attached to the humerus, and then muscles that move farther down the upper extremity. So we're starting on page 90. There's a chart there. We're actually going to come back to this chart a little bit later. But when we move into the extremities, we divide the extremities into regions, into compartments. And so I've listed here each of those compartments, the muscles that are in those compartments, and the nerves that innervate those compartments. And so I wanted the brachial plexus is the group of spinal ventral rami that innervate the upper extremity. We're not going to be looking very at the nerves for the scapula muscles, all right, but we will for the muscles of the upper extremity itself. So I wanted to introduce you to the brachial plexus, and then when we actually, in our next break, talk about the muscles of the arm, we'll start talking about these nerves. So you can see up here are the ventral rami. Remember the dorsal rami, the splenius capitis, and the erector spinae. These are the ventral rami. And we have C5, C6, C7, C8, and T1 ventral rami blending together, passing under the clavicle. So this would be the trapezius. These are muscles that we don't go over called the scalenes and the levator scapulae, and they pass between those and under the clavicle and then through the axilla. And then you can see all these branches coming off of them going to the muscles around the shoulder region and into the arm. You'll notice this letter M structure of the nerves. So right here, and here, and here, and here. And that, along with the posterior nerve, form the nerves that we're going to follow into the upper extremity. The next diagram shows that, and we looked at this last week, all right, in this pattern. So again, here are C5, C6, C7, C8, and T1 ventral rami. What I want you to know, I'm going to diagram on the board, and again, it's this M area. Okay, but I want to show you some of the nerves that you don't need to know and how they are components. So long thoracic, coming down here, actually goes to serratus anterior. Remember that muscle that wraps around, has its origin from the ribs and comes up under the scapula? So it's going to have in its nerves C5, C6, and a little bit of C7 as it goes to the serratus anterior. So any type of damage to the upper part of the brachial plexus, say if you're an infant being born and you're a breech and your head is too big for the birth canal and the obstetrician is trying to get your head out, it might get ridged to one side, especially if your heart rate is dropping and they're in a hurry to get you out. It's too late to go back the other way and take you out by C-section. Or maybe you're carrying a backpack with your A&P book and 5 atlases, and instead of carrying it on both shoulders, you got slung over one shoulder, and that strap of the backpack is going to compress on these ventral roots and can damage C5 and C6 more likely than C8 or T1. And so these nerves that have their primary source from those upper portions are going to be more affected than nerves downstream that are getting undamaged ventral roots. And so long thoracic nerve going to the serratus anterior, you can get that winging of the scapula where the vertebrae come out, all right, on one side or the other. You get this ridge extending outward. Here's the suprascapular nerve, just coming from C5 and C6. That goes to a muscle that helps you abduct your arm. And so there's several nerves that come up very high, all right? But we're going to be primarily interested in this region down here, that M formation, and the structures that you see in yellow are called the cords. So we have a lateral cord, a posterior cord, and a medial cord contributing to the M and the back of it, and that's what I'm going to diagram on the board. So this would be from the right extremity M shape. And again, this is in the axillary area. This information is earlier in your lecture notes. Remember, we started out talking about the nerves. So at the very beginning of the, thank you, page 52 is the brachial plexus. Came out a little faint, but it's that diagram that I have up on the screen now. And on page 50 is a list of the cords and the nerves that are coming off the cords, what I'm diagramming right now. Okay? The lateral cord forms a major nerve that goes into the anterior arm compartment, and that is known as the musculocutaneous nerve. And again, after our first break, we'll come back and actually be in the upper extremity and refer to these nerves. So that's musculocutaneous nerve. Off of the medial cord, this one travels down your medial forearm. It's the one that you hit when you hit your elbow and it tingles.
Ulnar.
Yes, very good. The ulnar nerve. And the two cords each give off a branch that forms a nerve that innervates the anterior forearm. And that's the one we'll end up talking about today at the very last part, and this is the median nerve. Off the posterior cord up high, right near the shoulder, is a nerve that crosses around the shoulder joint, and this is the axillary nerve. You're familiar with the deltoid muscle? It innervates that. That would be this one right here. And then the rest of the posterior cord does the entire posterior upper extremity, all the muscles of the back of your arm and forearm, and this is the radial nerve. So these are the nerves that you need to know for the upper extremity. You don't need to know, be able to draw or identify the trunks or the divisions of the brachial plexus, but these are the nerves of the brachial plexus. You do need to know, and they come from C5 through C8 and T1. All right, so the muscles that we're going to cover in this first section are muscles that have their origin on the scapula, cross the shoulder joint to attach and move the humerus. All right, so on Friday last week, we talked about muscles that inserted onto the scapula and either moved or stabilized the scapula. Now the scapula is going to be our point of origin. So if you look on the table or the chart on page 94, you'll see that for origin, all of them, except for the latissimus dorsi, are the scapula, and all of them insert onto the humerus. So that is the bone that they are going to move. So let's do the first one, which is pectoralis major. That's off of the anterior chest. We did pectoralis minor well, let's finish up with this image here, on Friday. So here's a picture of a cadaver. And we didn't have time to do cadaver today, so we're definitely going to do it on Thursday. All right, so if you wanted to bring the peppermints or whatever. So here's the deltoid muscle right here, and this is the axillary artery, and here are all the nerves that are passing through. The M structure that I talked about on the previous slide is right here, and then you're coming down here, and then this aspect here. And so this is the ulnar nerve, and here's musculocutaneous, and here's the musculocutaneous and median nerve. And so this is actually the most difficult part of the body to dissect in my mind, I mean, the pelvic cavity is difficult because it's tight and there's not very much room in there. But there's a lot of adipose tissue here. And when you first look at it, it doesn't look like this. You just see a lot of adipose tissue. And then you have to find all these structures in there without cutting them first. So I was teaching at the med school one year, and it looks like this up here in the neck as well. And after the first hour of dissection, a table of students called me over and said, "We can't find anything, can you help us?" And they had taken their scalpels and just cutting through everything was in little 1-inch pieces. I was like, no, I can't. But if you use the back of the scalpel or closed scissors, and before lab, you know what direction these nerves are traveling, then you can take that instrument and just go back and forth like this, and it's not going to cut it, because the nerves are tougher than the adipose tissue is, and you'll just kind of scrape out the adipose tissue, which is this little stuff here, in between each of that, and you can start to clean it out. And so, but you have to study before. I did a presentation for the medical students on Friday with our cadavers, and, well, pre-med students. And you have to really study the material before you go to the cadaver lab, and the models and the diagrams, and know what you're looking for to be able to do that orientation. All right, so let's look at pectoralis major. Remember, pectoralis minor was a muscle that was superficial to this, and the major minor components don't have any relationship like they do with zygomaticus minor and zygomaticus major. Here they really are two distinctive muscles. Pectoralis minor, if you recall, had its origin off of the ribs and inserted onto the coracoid process and moved or stabilized the scapula. Pectoralis major has its origin off of the sternum and the clavicle and inserts and moves the humerus. So completely different muscles. So let me take a moment just to draw those attachment sites. Okay, we talked about how important it was to recognize the location of the muscle. Obviously, if it doesn't cross a joint, it's not going to move the bone on the other side of that joint, okay? And then we need to recognize whether it crosses that joint in front or behind or beside. So we're looking at muscles that are going to be in both locations. This particular muscle crosses in front of the joint. So what movement are we talking about when we're talking about in front of a joint? It's going to be able to move the humerus this direction, and it's going to be able to pull the humerus across in this direction. So if we look at the muscle attachments, the origin is from the clavicle and the sternum. Onto the humerus. So because it's anterior, muscles that cross the shoulder joint anterior are going to be able to do flexion of the humerus, because that's what it's inserting onto. And flexion, remember, is decreasing the angle of a joint. So doing this. Pectoralis major is going to be able to do this, and then pulling it across close to the midline. What do we call that? Adduction. Okay? Adduction, but I say AD just for abduction, and I spell it, or write it rather, like that. Okay, so adduction, pulling across to the midline, adding it to the midline, if you will. So that's what pectoralis major is going to be able to do anterior to the joint. And you don't need to know the nerve to innervate this or pectoral nerves, but you don't need to know innervation for pectoralis major. So no scapula involved at all. Okay, now let's look at the muscles of the back. And we're looking at not the most superficial, but deep to the trapezius. And all of these muscles are going to have their origin from the scapula, except for the last one, the latissimus dorsi. Most of them are going to attach to the greater tubercle. So let's look at those. 4 of these muscles are identified on your lecture notes as rotator cuff muscles. You've probably heard that term. Somebody says, I tore my rotator cuff. It's a common injury for people that throw things, not glasses and lamps and stuff like that. I'm talking about footballs and baseballs, all right, that do it over and over and over. The rotator cuff provides an external support to the shoulder joint. It's outside the joint capsule, but it supports it. Anterior, lateral, and posterior, but not inferior. All right, so here's the greater tubercle. Remember, the greater tubercle is a lateral process. So if we look at the bone, it's this larger bump right here, whereas the anterior tubercle is smaller. Okay, you got a question, Gretchen?
I have a question.
Yes.
It provides support of
The shoulder joint, external to the joint capsule. All right. So I'm going to draw another view from the posterior aspect. This is an anterior view. And now muscles that are posterior to the shoulder joint are going to be able, instead of flexion, are going to do extension. And another major movement with these muscles is this movement, lateral rotation or external rotation. And I'll illustrate that for you in just a moment. We have medial rotation, but I'm going to kind of put that in parentheses because they're found both in front of and behind the joint. The lateral or external rotation. Rotation means the bone has to move the entire length of the bone. All right? So if I use this pen, flexion was decreasing the angle of a joint, extension is increasing, adduction moving towards the midline, abduction away, and rotation is the entire bone. So if I'm the humerus, all right, and I'm a right humerus, this would be external rotation, and this would be internal rotation, or lateral rotation and medial rotation. Now I'll show you with my humerus itself, covered up with skin and muscle. I've got my elbow bent, so I'm not doing this. All right, so this would be external rotation or lateral rotation, and this is internal or medial. The skeletal humerus doesn't move very well because of its attachments. All right, but this would be medial rotation, turning it this direction and now moving it out. Can't get it to go any farther. It's lateral. So medial, lateral. And the humerus is rotating, okay, the entire bone. And if we have a movement that combines flexion and extension and adduction, we do this movement. All right? So it's taking the bone, holding it fixed, and circumscribing a circle with the other end. So I can do it like this. I can't do it with my elbow. Even when I'm doing this, I'm really rotating my humerus. So this movement is known as circumduction. Okay? So I can circumduct my finger. I can circumduct my wrist. Can I rotate my finger? Can I take that? If I do this, I'm really doing the radius. All right? So I can circumduct my finger, but I can't rotate it. Because I can't take that whole bone and move it in a circle. All right. And then the lateral, if the muscle crosses the joint laterally, what do we call that movement? Away from the midline? Abduction.
muscle crosses the joint.
Lateral. The lateral aspect. Okay, while I'm drawing a posterior view of the bones, it would be helpful if you wanted to go and get, and you can borrow this one here, the upper extremity models, because all the muscles I'm going to talk about now you can see on those models. All right, it would be helpful for you to visualize them on there.
Which one is the internal rotation?
I'm going to talk about them. The pectoralis major does it a little bit, but I don't. They're the latissimus dorsi.
I worded it wrong. I'm sorry.
Oh, okay.
Muscles that cross the joint posteriorly, anteriorly, or laterally.
We don't have any that, I mean, from the anterior medial, so they're kind of the midline.
Oh, look at your cute
So
shoes. They don't fall under that.
yeah, we don't have a kind of a big medial to the joint, but yeah.
He just likes to move because Yorkshire thoroughly bred, and since his system under one of these is working 15-hour days. Like I had to work 15 hours last time. He works his is starting to 3 He doesn't get off until like he probably got
that money.
Sure. Oh, yeah.
I know. So he's
So who takes care of the puppies then?
These roommates.
Oh.
So he was like, I just got off. He's like, I just woke up. He's like, I worked 15 hours. I was like, it's recording. Don't worry.
Yeah. Oh my gosh, I was watching this all last night. And let me just tell you, I missed so much in the class. And then when I watch that over again, it's funny because like she'll ask questions and I'll know the answers now because I've watched it again. And like the class is quiet, she'll be like for example, one yesterday it kind of made me laugh because she's like, okay, so we have, what kind of channels are we going to find here? It's similar to the axon hammer. And I'm like, low threshold, low threshold. And she's like waiting for people to answer. And then like a second later, she's like, low threshold. And I was like, okay.
Okay, so I've drawn the posterior view. This would be the spine, and I've taken off the lesser tubercle because it's a posterior view. And then I redrew the anterior view without the sternum. And for the first one that we need here, I still need to put the clavicle in. All right, so the deltoid is superficial to these other muscles, but it parallels the attachment of the trapezius.
Oops.
So the trapezius muscle is going to come down from, or go up from the spine, up the neck, and from the clavicle. So if we look at the top, look at a downward view on the shoulder. Where's my downward view on the shoulder? Here. So you can see the clavicle, and here's the spine, and that would be the attachment for the trapezius above. And then from below, the deltoid. So the trapezius is having its origin from the, actually it's having its insertion on the clavicle and the spine of the scapula to lift it up. And the deltoid is going to have its origin from those same processes, from the inferior aspect. And so we find the deltoid on both the anterior and the posterior and lateral aspects of the shoulder joint. So coming from the anterior view, anybody know where without looking at your lecture notes, what's the process that the deltoid inserts on? Remember from the bone? It's named for the muscle?
No, the
Deltoid tuberosity. And that's a lateral process. Okay? It's this rough area. So we take our fingers from the greater tubercle and run them down. We can feel that rough area on the lateral process of the deltoid. So it's all tapering together to attach to that point. So coming on to the over, we see all of that attaching from the clavicle, and the same thing from the spine. So we have both an anterior and a posterior view of the deltoid muscle. So if we look at those fibers, the fibers from the clavicle are anterior to the joint. So the deltoid can flex and adduct a little bit of, well, not much, but mostly flex the humerus. It's not considered to be an adductor, actually, because it's too high. So it can flex it. From the posterior view, it can extend it. And then this is the agonist, the muscle with the strongest force for abducting the humerus. Okay. And that's its lateral approach. And I'm going to erase this and we draw it because the rest of the muscles I need to talk about lie deep to the deltoid. So on your models, the deltoid is taken off. So let me go grab one.
Oh, I just grabbed something.
That's okay. I was going to have you take it off in a couple of minutes anyway. They're all over here. So you can see its origin forms this U because it's the clavicle and the spine of the scapula. And so for those of you that have it, you can see it, sorry. But it fits like this. Okay? So it's found both in front of and the lateral aspect and behind, having its origin off of the spine, and that's why it can do all of those movements. So everything, it really is too vertical to do adduction, but all the other movements. So go ahead and take the deltoid off, and we're going to look at the muscles that lie deep to it.